Hi, everyone, and welcome back to Medscope, where we spotlight fascinating stories in medicine and the people who live them. Today's guest is Dr. Fatma Sheikh, and a psychiatrist with years of clinical experience treating patients with some of the most challenging psychiatric conditions, from severe mood disorders to complex trauma cases. Originally from Pakistan, Dr. Sheikh grew up in California. She attended St. George's University in Grenada for med school. She did her psychiatry residency at the University of Oklahoma and child psychiatry fellowship at the University of Southern California. She's now married and lives and practices in Oklahoma. Dr. Sheikh, welcome to Medscope.
Thank you so much for having me.
So I'd love to start with your story. What led you to choose psychiatry, especially knowing how emotionally demanding the field can be?
So it's actually kind of interesting because I ended up in psychiatry. I kind of fell into it in a way. I actually thought from the age that I was 12, I knew I wanted to be a doctor, and I actually knew I wanted to be an OBGYN. And so for all those years, that was determined, I was pretty much determined that that was what I was going to do. So when I ended up getting to med school, I did my OBGYN rotation. And I loved the C sections, the natural births, and the clinic, but I really, really hated the GYN surgeries where they would basically operate on the uterus. A lot of them were laparoscopic. They could be extremely long, and I was just like, I don't think I could do that part of the job. The other thing is, I also realized that as much as I liked the idea of doing something surgical, I wasn't sure if that was really my calling. It was something. And then the hours were very, they were going to be very challenging. The residents always seemed really unhappy, and they seemed miserable,
Oh, that's
tired,
nice.
and just very unhappy. And I thought maybe at first it was just the hospital I was rotating at. So I did two other OBGYN rotations, and they were just as unhappy at those other hospitals.
Oh, wow.
So something didn't sit right. Something inside me was like, okay, this may not be it for me.
Yeah.
So I kind of went into a panic because it was 2 weeks before I was supposed to turn in my applications to apply for residency. So all of a sudden I had no idea what I was going to do. So I went into pediatrics. I thought that would be a natural fit. My mother had a daycare, a licensed family daycare. I worked with kids my entire life in the daycare. I was a nanny. I had tutored in college. And so I was like, this is, so I went into peds, got accepted, went to the University of Oklahoma for pediatrics. I started thinking about doing fellowship, and I thought I wanted to do child psychiatry. But in order to do that, you actually have to do a psychiatry residency. You can't do pediatrics. And so so you have to do psychiatry as a residency and then do child psychiatry as a fellowship. So if I was going to do that, I would have to switch residency programs. And that's pretty much what ended up happening. So I talked to my program director. I thought I was going to be a child psychiatrist. So I talked to them, and they helped me transferring into from peds to psychiatry. And I really loved what I was doing in psychiatry. I went to child psychiatry for fellowship. Absolutely did not like that very much, and ended up working with adults. But it's like it was kind of a little bit of a meandering path, but I got to somewhere that I ended up loving very much. The other thing that I feel like really helped me, or when psychiatry came into the picture, it made it a little bit more familiar, was I have a close family member that has a mental illness. And so because of that, I feel like I had a very personal experience that led me to understand what psychiatry meant and what patients go through and what families go through. I actually, to this day, I feel like if that wasn't the case, I may not have appreciated psychiatry as much as I did. So when I kind of fell into it, I almost feel like that's where I was supposed to be.
Yeah, where you belonged.
Yeah.
All right. So you work closely with patients going through some of the most difficult mental health challenges. What's one thing people often misunderstand about psychiatric care?
I feel like oftentimes I have patients that will come into my office and they think I'm a pill popper. That's literally what they will call us, because the psychologists who are the PhDs and licensed clinical social workers, they do the therapy part. But when they see psychiatrists, they're like, "Oh, so you're the doctor that's just going to push pills my way."
Yeah.
And I explained to them there's a lot of education that goes into it, but my visits are, and our work together is so much more than just prescribing medication. So I do, yes, of course, when I do prescribe medication, I explain medications to them. We talk about, answer all their questions. But in addition to the medication, there's a lot of other education about health and well-being and lifestyle changes.
Well, yeah.
Because feeling better doesn't just involve taking medications. You have to do lots of other things to help that. And so I think that's probably one of the bigger misunderstandings.
Do you prescribe something to every single one of your patients or no? Like
the majority of them, yes, but there have been several occasions, and I would say, I have patients that basically are not taking medications but coming in to see me. They, it's more of a kind of, it's a little bit more therapy, but they are interested. They always feel like, okay, I might be interested in medications at some point, so that's why they keep contact. But no, I don't. Sometimes patients come in and I tell them, like, I don't think medications are going to be necessary for you. I think you should just work on therapy, make a few lifestyle changes, and we don't need to go the medication route.
Oh, that's nice. I thought every single patient of yours was prescribed.
Yeah, prescribed. Most of them are, but some of them no.
Yeah. Okay.
A handful, I would say.
Yeah. So, would you feel comfortable sharing a case or experience that really stuck with you, or maybe something that challenged you as a provider or helped you grow?
There's so many stories to pick from, but I think that one that kind of comes into mind that I actually share with my residents when I supervise them too. I had a woman come into me. I was treating her for anxiety, and I was prescribing her a couple of different medications to help manage her depression and anxiety. One of them is a medication called buspirone, which is used for generalized anxiety. And it is pretty much like a sugar pill for most people when it comes to side effect profile. And the reason I say that is because, for a lot of medications, sometimes some medicines have a lot of side effects, some of them have less, and some of them are in the middle.
Yeah.
Buspirone really doesn't have any side effects. Like, patients rarely complain about issues with buspirone. So with this patient, she told me she had been on this medicine in the past, and but it was stopped because there was some at the time she experienced problems with tendonitis, Achilles tendonitis, and her doctors at the time thought it might be related to the buspirone, but because she had a lot of other changes, they couldn't really identify. So we were still trying to treat her anxiety. Buspirone can be very helpful, and she wanted to retry the medication. So I had asked her, I had told her, I said, look, if we try this medication, I need you to make sure that if you start having any type of ankle pain or any type of, soreness in that area, that you stop the medication and let me know.
Yeah.
We must have reviewed this. I had this, like, it was I stated it a couple of times. She verbalized understanding.
Yeah.
Everything happened. A couple of months later, she comes in and she's hobbling on her. She was hobbling into my office because she couldn't walk well with her feet. And so she sat down, and I said, hey, I was like, what happened? And she's like, well, I'm on the buspirone and it's causing me the tendonitis. And, and so I asked her, I was like, so why didn't you stop? Yeah. Why didn't you stop? Remember, we had a plan. You were going to let me know if you had a problem. And she said, well, I don't always remember everything that we talk about, so I guess I must not have remembered that.
Oh, wow.
Yeah.
So,
and so I was I don't know. I think what that experience taught me is I take a lot of pride in, and I always try to make sure my patients, understand things. Like, I write things down for them. I give them reminders. We go over stuff. I have them repeat it back to me. And I always feel like I've done my part. So they're going to know this. Yeah. Well, they're going to know now. But what that experience really taught me is that regardless, like, sometimes even though I might think something has been conveyed, it may not really be registering on the other end. So it just kind of helped me, I guess, learn for expectations. Yeah, you learn a lot because you're like, well, I could have sworn I did everything I possibly could. And it's just one of those things where,
wow,
Wow.
That's a nice excuse, though. I don't really remember everything you say. Okay. Our next question is, have you ever had to make a really tough decision in a psychiatric crisis situation? How do you stay grounded in that moment?
So the answer is yes. And I think there's probably several decisions, but I think the decision that's hardest to make is when a patient comes in and I know they're sick enough that they need to be admitted,
Mm-hmm.
but the patient does not want to be admitted.
Oh.
And then I have to then do what's called an involuntary admission. And so that's very difficult because the
Mm-hmm.
patients often, sometimes they get upset, sometimes they get angry and they're like, how could you do this? Why are
Yeah.
you admitting me? And I don't think I need to be admitted. It's a hard thing to do because as a doctor, most of us, we like to feel like we're doing something to help our patients, and we don't, if I don't want to do something to upset them, but sometimes I have to do something that they may not think is right, but I know I need to do.
Mm-hmm.
And so involuntary admissions are, I feel like, are some of the hardest things that I feel like I don't like doing, but sometimes I have to do.
Mm-hmm.
So that would be the hard decision. And then I think the second part of the question,
how do you stay grounded in that moment?
oh gosh. It's hard because you have a bunch of thoughts going through your head, and you're like, should I, sometimes there's even a little bit of self-doubt when you're like, maybe I don't need to, maybe I should. But at the end of the day, I have to ask myself, I have to, try to rein things in, remind myself I'm making this decision and why. And the big question I have to answer is, if I let this patient go home today, am I still going to be thinking about this later tonight? And if the answer is yes, then the admission needs to happen. Because what that means is that there's some part of me that's going to be concerned if they go home, and that's a red flag. So
how, like, obviously you have some sort of relationship with every patient of yours. How is that affected after they're out?
That's an excellent question. Sometimes they ask for a change of provider. A lot of times when you involuntarily admit a patient, you can be with them for years, but that can sometimes break rapport because they don't see you as being on their side anymore.
They don't trust you as much.
The trust is kind of broken, which is sad. And that's happened, I think, once or twice in my 10-year career at the where I work, at the VA hospital. But other times, sometimes patients, it brings a level of understanding about their illness that they didn't have before. So it can go either way. But sometimes it can break rapport.
Wow, that part's sad.
Yeah, it is.
Yeah. Okay. So my next question is, have you ever worked with patients in inpatient psychiatric units or emergency settings? If so, how different is that environment from what people might imagine?
I have worked with patients on inpatient units and in emergency settings. We do both. So I work as an outpatient physician that's my normal job. That's what I do. But when I'm on call at the hospital that I work at, I have to work on the inpatient unit. And so so on the weekends or after hours if we're on call, that's what we're doing. In the emergency room setting, it's been a while. I have practiced in an emergency room setting for psychiatry, but we have there are actually psychiatric ERs that you can. There's
really?
ERs, which are crisis centers usually, that you can have specifically for patients who come in for mental health crises. At our hospital, we have a regular emergency room, but we do have mental health professionals that work downstairs in the emergency room that basically help deal with mental health crises. So I think your question was, so I did, so I have worked in both of those situations. And the environment, I would say a psychiatric unit is very different from a medical ward. Like if somebody's admitted for something like pneumonia, they're going to be admitted to a medical ward. The psychiatric ward, they're there for treatment of mental health conditions, but it's a locked unit. You can't come and go as you want. There's lots of things that patients are not allowed to have, like basic things like you can't have shoes with laces. If you have shoes with laces, you have to take the laces out. You can only wear the shoes and the laces have to be confiscated. There's, of course, people there with various degrees of illness. So, there could be somebody with schizophrenia or dementia, right? And somebody might just be there for a suicide attempt, after a depressive episode. So there's a lot of different needs, but everyone's on that one unit. And there's there's not as much privacy because they have separate rooms, but the nurses have to constantly do safety checks. So it's a very different place compared to a medical ward.
Were you scared when you first went there? Is it scary?
It's not scary. No, I wasn't. Because by the time, I started working in residency, I'd gone through medical school. So you've already been exposed to being in a hospital. You've rotated through many different situations. So no, I wasn't scared. And I think psychiatric units are a place where there's more, because again, patients have they're in different levels of awareness, different degrees of illness, and sometimes there are patients that can be aggressive, like verbally or physically. So and that can happen. I would say that is something that happens more often on psychiatric wards than it would on a medical ward.
Yeah, I see. Yeah, okay. So my next question is, have you ever had moments where the emotional weight of your work felt too much? How do you cope with that side of the job?
Oh, yes, absolutely. I think anybody who's practiced medicine long enough has definitely had cases where, that are sad or that get to them personally.
Yeah.
I think I definitely have had my share. In mental health, I think one thing that's different from us compared to other fields of medicine is, unfortunately, we do have patients that commit suicide. And so it's not that patients don't die or pass away in other areas of medicine. Like if you can be an internal medicine doctor and one of your patients can die from a heart attack. But that's a little different because that's a natural thing that can happen that took that patient away, right? But when a patient of yours commits suicide, there's a level of accountability or guilt, or sometimes you feel there's a whole range of emotions, and it's because that's not a natural event. And
that's
it
what
seems
you
like
were
that's
trying to deal with.
Yes, right. That was the worst outcome, and it happened. I can truly say that I didn't know what that would feel like as a professional until, unfortunately, I had when it happened the first time to one of my patients. I did not understand the degree of, there's almost a certain amount of grief that you go through. You're kind of grieving the loss and also trying to figure out what could have been done differently. And that doesn't happen when people die in other ways in other areas. So there's that part of it. Now, how do you deal with that? Or other things that can happen that are with really tough cases. I think having positive things in your life, family, faith. I know it sounds very, very
cliche,
cliche, but it truly is. If I have a tough day, being able to come home and, of course, because of HIPAA, I can't share details, but knowing people, having a supportive family, and having my belief system and my faith has definitely helped me get through those things. Doing positive things in your life, having hobbies, things you enjoy, all of that truly matters when you're going through a rough time.
Yeah. Wow. I never really thought of that side.
I don't think you do until, I remember I started practicing. It was like, it's not something I'll never forget. I went to a conference. I started practicing after fellowship. November 2015 was when I started working at my current hospital. I went to a conference, a psychiatric conference in 2018. At that conference, they had a lecture about how clinicians can deal with the hardships they face after a patient commits suicide. Now, I listened to that lecture just fine. Up until that point, I had not gone through that experience. Well, 4 months later, I had a patient that did. And all of a sudden, this flood of emotions that I had no idea, I cannot describe it. It's just, all of a sudden, like, that conference had that lecture had a completely different meaning. And it's not something that I think I would have understood until the unfortunate happened.
What about, like, let's say you're at work like a regular day, and then you get notified with this information that one of your patients have passed. How do you and your next patient is like about to come in, how do you like cope with that?
You literally have to compartmentalize. It's and that exact scenario has taken place for me. I was at work. I've had, like I said, I've been working for about 10 years, and I've had 3 patients that committed suicide during those 10 years. And it hit me just as hard every time. It doesn't get any easier in that regard. but and how you find out and the circumstances were different in each situation.
Mhm.
So I had that very thing take place. I was in my clinic, I was seeing patients, and I got a message from our suicide prevention department that one of my
Oh.
patients, their family had called to notify them that this patient had committed
Mhm.
suicide. And so they let me know. They said, we wanted to let you know, you're the clinician, out of professional
Mhm.
courtesy, we wanted to let you know. And I was going to be seeing my next patient in like 10 minutes.
Oh.
And so there's the initial shock and then there's the grief, but I know that my next patient needs me, so I
Mhm.
have to be
You gotta keep
present.
going, yeah.
Yeah, so you have to, and I had to wait till the end of the day because I found out that morning
Oh.
I had still had a full day of patients left.
Oh,
And
wow.
so, yeah,
Yeah.
so just kind of, you do what you need to do,
Mhm.
and try to address the needs of the people that I did have to see that day. And then, yeah, I processed it later.
Yeah, that's not easy. Okay. My next question, zooming out a bit, what do you think is one of the biggest challenges healthcare workers face today? Whether it's systemic issues like insurance or day-to-day pressures like time constraints.
Oh gosh, that's an excellent question. We have so many things that we are facing, I think, unfortunately, as a healthcare system.
Mm-hmm.
You've already named insurance. Absolutely. That is a big problem because there's people who are unable to pay,
Mm-hmm.
or have insurance or don't have insurance. And if they do, they're unable to pay the copays or the fees.
Yeah.
Um, and then the cost of medicine, like how bills are, how hospitals are billed, the varying fees from hospital to
Mm-hmm.
hospital for the same service.
Yeah.
um, that is definitely a problem. The time constraints, absolutely. I'm very fortunate that at the VA I get 30 minutes per patient,
Mm-hmm.
which in the private sector you get 15 or 20 minutes. And per patient, and I'm not sure how that's even possible. Because I feel like you just start saying hello and 10 minutes
Yeah.
have gone by, and and even half an hour, I go over. If I need to go over, I do, absolutely,
Mm-hmm.
with patients. I feel like physicians are treated like doctor factories, where it's
Mm-hmm.
like, you just come, patients just come in. It's kind of like a where number one, number two, number three, you're just
Yeah.
seeing patients as numbers, and they're trying to
Finish the day.
yeah, it's a for-profit industry.
Yeah.
Unfortunately, medicine is a for-profit industry in the United
Yeah.
States. The other big issue that I think that we face in healthcare is that we have practitioners who have gone to school, like nurse practitioners and PAs,
Mm-hmm.
and they absolutely have a role in the healthcare system. But unfortunately, I feel like sometimes the training, they're expected to do the jobs of physicians, like people who have gone
Oh.
to medical school,
Mm-hmm.
and I think that's a disservice to
Yeah.
the patients. It's also, I think, a disservice to the clinicians who are coming from these
Mm-hmm.
other educational backgrounds,
Yeah.
because I don't think, like, we go to school, that much school, for a reason.
Exactly.
There's
Yeah.
a lot to learn. So I think
Yeah.
that can be a problem too
Mm-hmm.
on both ends.
Yeah. No, understandable. I mean, that makes complete sense. Yeah, okay. My next question. Do you feel like mental health professionals get the same level of recognition and support as other physicians, or is there still a sense of being on the margins of the system?
I feel that even, and the interesting is like, I realized that when I went into psychiatry,
Yeah.
the idea is that you're not like a real quote unquote doctor. Like, I'm an
Oh.
MD,
Mm-hmm.
but um, there are people even in the healthcare community, like other physicians, who don't consider psychiatrists to be real quote unquote doctors.
Oh.
Um, and it's very sad,
Yeah.
but it's the truth. And it's because I'm not doing procedures, I'm not doing physical
Mm-hmm.
exams. So that idea of, like, you went to medical school and you learn all these different things, like,
Mm-hmm.
in terms of again, procedures and exams and things like that. I'm not using any of those skills anymore. But I feel the perception um, that psychiatrists are less than some of our other medical colleagues. I think that's something that's gotten better over time, but it's definitely
Mm-hmm.
still there
It's still
sometimes.
there.
Yeah. But I feel like I feel well supported in my hospital. I feel
Mm-hmm.
like I've only encountered in my own personal life, I've only encountered that maybe a couple of times.
Mm-hmm.
Um, and I'm very fortunate to be able to say that. I feel like there's a greater appreciation, sorry, for psychiatrists and mental health in general, because of how prevalent people talk about mental health more now than they did 30, 40 years ago.
Oh, yeah.
And the number of patients that are, or people that are affected by mental health diagnoses, I think is much more it's much more prevalent and known because there's a lot more education about it. So I feel like for that reason in of itself, I think our need is much more recognized now than it was like 40, 50 years ago.
Oh yeah, I think on that end it's getting just a bit better.
Yes, absolutely. Yes.
Yeah, makes sense. All right. And if you had the power to change just one thing about how the system works from the perspective of a psychiatrist, what would that be?
Now, is that in psychiatry itself or medicine in general?
I mean, whichever you would like to answer, to be honest.
I feel like I would like to be able to help define the roles of different providers a little bit better, because I feel like as a hospital system, I feel like when I was mentioning to you that we have like nurse practitioners and PAs that work in different settings, but sometimes they're like the primary psychiatrist for, and I'm just speaking about like psychiatry. This is true for I feel like even other fields of medicine, but just speaking from psychiatry, like I feel like there's definitely a role, like when it comes to providing patients with education and and giving like, or maybe doing certain types of appointments. I think that they can be very useful and helpful there. But I feel like in other situations, they might be the provider, like the prescribing provider, and sometimes they're not able to prescribe comfortably, or they don't feel like they know exactly how to prescribe or what to prescribe. I feel like if we can support our different healthcare providers in different settings, and hopefully try to come up with a system that works better for the patient as well as the providers, I feel like that would be a little bit more effective.
Yeah.
But I feel like that's probably true in other areas of medicine as well. But that's just my personal opinion.
Yeah, that makes sense. Okay, my last question for you. If a student came to you today, whether they're interested in psychiatry or just unsure about entering the medical field, what would you want them to know?
It's a long road.
Yeah.
For schooling. It takes years and years, and that's not to discourage them, but I think the main thing the reason I point that out is because if they really want it, they'll do it, because like hundreds and thousands of us have before them.
Yeah.
But I would definitely tell them that if this is truly what you want to do, then absolutely do it. It's it's hard work and it's a very long time, but if you love what you do and you're passionate about providing care, it'll be a good fit.
Yeah.
But if you're not, then you should definitely reconsider.
Yeah. That makes sense. Well, okay, Dr. Sheikh, thank you so much for sharing your story and your experiences and your insight with us today. Talking about mental health requires vulnerability, strength, and compassion, and you definitely brought all of those today to this conversation. And to our listeners, thank you so much for tuning in today. These are the stories that remind us why medicine matters, and we're just getting started. And see you next time. Bye.